Anticoagulation, Initiation, Watford General Hospital, Guide for all you doctors. Around 800,000 people in England are known to be at risk of stroke from AF. Of these, half are taking anticoagulation, with one third taking aspirin as a mode of anticoagulation, which is no longer recommended as per NICE Guidelines 2007. Two-thirds of people admitted to hospital with a stroke on the background of AF are not taking recommended anticoagulants. The most commonly seen reasons for initiating anticoagulation in clinical practice include atrial fibrillation, venous thromboembolism, and patients with mechanical valves. Less commonly seen, but an indication for anticoagulation, are conditions such as cardiomyopathy, thrombophilias, and antiphospholipid syndrome. Atrial fibrillation itself as a condition is dangerous, with approximately 5% risk of stroke per year if left untreated, is common, with 5 to 10% of patients above the age of 65 thought to suffer from the condition, and we know that treatment for stroke prevention is effective, with NICE estimating that 7,000 strokes and 2,000 premature deaths could be avoided per annum. Anticoagulation in atrial fibrillation is recommended when the benefits outweigh the risk of bleeding. It is important to formally assess the risk of bleeding against the benefit of stroke prevention in patients with atrial fibrillation, and the two most common ways of doing so are by making use of formal scoring systems in the way of the CHAD-VASc and the HAS-BLOOD scores. The CHAD-VASc score itself assesses a patient's annual risk of stroke per annum in patients known to have atrial fibrillation. It involves certain parameters which are thought to increase the patient's risk: congestive cardiac failure, hypertension, patients above the age of 75, diabetics, patients with known strokes or transient ischemic attacks in the past, vascular disease, age of patients between 65 to 74, and female genders. The HAS-BLOOD score itself assesses a patient's annual risk of bleeding whilst on oral anticoagulants and makes use of patients who are known to have uncontrolled hypertension with a systolic greater than 160 millimeters of mercury, known abnormal renal or liver function, a previous history of stroke or previous major bleeding or predisposition to bleeding, patients with known labile INRs, elderly patients above the age of 65, drugs which increase the risk of bleeding, such as antiplatelets and nonsteroidals, or patients who have more than 8 alcoholic beverages per week. It is recommended by NICE that the CHAD-VASc score should be used to assess stroke risk in all patients with atrial fibrillation, regardless of AF being paroxysmal, persistent, or permanent, patients with known atrial flutter, or in patients known to have a continual risk of arrhythmia recurrence after cardioversion back to sinus rhythm. It is recommended that all patients with a CHAD-VASc score of 2 or above should be initiated on anticoagulation, and it should be considered in all male patients who have a score of 1 or above. The two most commonly used forms of anticoagulation are warfarin or novel oral anticoagulants, which could be in the form of apixaban, dabigatran, or rivaroxaban. Whilst aspirin used to be used as a formal mode of anticoagulation, it is no longer recommended as per NICE Guidelines 2007, and it has a poor efficacy in reducing the risk of stroke compared to oral anticoagulants, whilst having no significant difference in the risk of major bleeding. NICE recommend that warfarin should still be offered to all patients, providing patients with the choice to choose between warfarin and novel oral anticoagulants. Warfarin itself is a vitamin K epoxide reductase inhibitor, which thus inhibits the synthesis of active forms of clotting factors 2, 7, 9, 10, as well as anticoagulant protein CNS. Apixaban and rivaroxaban both work by directly inhibiting factor 10A and thus prevent thrombin generation and thrombus development. Dabigatran is a direct thrombin inhibitor, thus inhibiting the conversion of fibrinogen to fibrin. NOACs themselves are known not to be inferior for stroke or embolism prevention in patients on a background of atrial fibrillation, have a reduced risk of hemorrhagic stroke, have a reduced risk of fatal bleeding events with clinical trials showing reduced hemorrhagic stroke and intracerebral hemorrhage compared to warfarin, however do have a slightly increased risk of GI bleeds. It is thought that overall NOACs are more cost effective on account of reduced monitoring and ongoing healthcare costs. However, there is currently a lack of an antidote present for NOACs, but in the event of a bleed, local hematology departments can be contacted for advice. Potential candidates for NOACs include patients who have difficulty controlling their INR despite their best efforts, who spend less than 65% of their time in the therapeutic range. Patients who are at high risk of warfarin complications, patients taking numerous drugs, increasing the risk of drug-drug interactions, and patients who prefer a drug that is not interfering with lifestyle and does not require regular monitoring. Patients with AF who still require warfarin compared to novel oral anticoagulants are renal patients, patients with valvular atrial fibrillation as opposed to non-valvular AF in which NOACs can be indicated, patients have concerns regarding lack of antidotes, and patients with mechanical valve prosthesis. It is important to ensure patients are involved in the decision regarding whether warfarin or NOACs are chosen as a form of anticoagulant treatment. NICE says that novel oral anticoagulants should be offered where appropriate, and there is an essential need for counseling of all patients in requiring anticoagulation therapy. NICE recommend that the decision about whether to start treatment with a novel oral anticoagulant should be after an informed discussion between the clinician and the patient about the risk and benefits compared to warfarin. It is important when initiating anticoagulation for atrial fibrillation for stroke prevention at Watford General Hospital's acute admissions unit to educate the patient, thus empowering them in their own healthcare, allowing them to take a mode of anticoagulation that they are most likely to take on a regular and daily basis. It is important to make use of the anticoagulation sticker, which is available within each bay within the acute admissions unit, which provides key information regarding anticoagulation initiation. Looking at the sticker in more detail, it allows for all patient demographics to be clearly documented within the patient's notes, allows us to formally document a patient's CHAD-VAS and HAS-blood score, whilst reminding us to document key baseline investigations, including a creatinine clearance and weight, which would be essential when initiating a novel oral anticoagulant, ensuring appropriate doses are initiated. The sticker provides key information regarding when to use standard dosing compared to reduced dosing, and also advises when to avoid making use of warfarin, apixaban, rivaroxaban, or dabigatran. It is important to ensure that patients have been supplied with an alert card and counselor booklet at the time of counselling and have signed the novel oral anticoagulation agreement form as available on the Trust intranet. It is important to recognize a doctor's responsibility. It is our responsibility to consider anticoagulation in all patients in need. It is our responsibility to appropriately counsel patients regarding the need for anticoagulation and its potential benefits and risks. It is our responsibility to offer patients the choice of oral anticoagulation. It is our responsibility to ensure appropriate doses are prescribed and ensuring appropriate follow-up. It is our responsibility to ensure that we have accurately documented patient counselling, which we can do by making use of the anticoagulation sticker available within the acute admissions unit within the patient's notes. Thank you for your attention.